his expertise, his knowledge, he's a real medical device designer. He's a real innovator. I've been fortunate to collaborate with him. He's come to the lab, and I learned so much from him. So it's just going to be exciting to hear how these devices, how this field has moved forward, and how it's really changing lives and millions of people throughout. And we're, I think, fortunate then to have a rising star and a continued star in the field of cardiac devices. So with that, Gabe, please.
So Paul and audience, colleagues, thanks for allowing me to talk today to you at this prestigious event on medical devices. I was just walking down the hallway and seeing all the different exciting talks in ophthalmology, neurology. This is clearly the place to be, and I think that it's going to be spotlighting and highlighting a lot of really new stuff that's out there. You know, this has been out in the States for about going on close to a year, but it's really in its infancy because we're just beginning to study this technology and just beginning to understand where we're going to be able to go forward with it. So it's really a pleasure and a privilege of mine to be able to come here and talk to you all today about this, and I really welcome your questions. And no question is a dumb one with this. This is how this whole field is going to evolve. So anything that sparks your interest, just please let me know. So I'm Dr. Loor. I'm one of the assistant professors in cardiac surgery, cardiothoracic surgery at the University of Minnesota. So heart transplants, there are about 2,000 heart transplants done annually. In addition, there are about 2,000 lung transplants done annually, and that's steadily increased over the past decade. We're faced in the current era with increased complexity related to the recipients that we're transplanting, as well as the donors that we're using to transplant. Waitlist times, complications, are all steadily increasing in some ways. In other ways, ICU and technical aspects of the surgery have been able to keep that steady. But we're dealing with such a complex milieu in lung transplant right now and heart transplant that we have to try to find ways to improve the quality of the organs that we transplant. In addition, 80% of organs that are offered at any given time, whether it be on one evening on call or an entire month, 80% of them are wasted, and only 20% are used. So that means that for one patient, 10 offers, only 2 would be suitable. On average, 60% of patients on the wait list are transplanted within a year. 40% are either removed from the list for a variety of reasons or die on the list. We have this issue of primary graft dysfunction. So when we transplant the lung, it's not a guarantee it's going to work right away. To be honest with you, immunology has become so good, and our ability to predict any problems with the immunology are so stellar right now that it's not so much an issue of rejection as much as an ischemic type injury that the lungs sustain in transport and in installation into the new patient. So it turns out that about 15% of patients will develop severe PGD, or severe primary graft dysfunction. And what that means is that the lungs aren't working, and that usually takes about 2-3 days or even up to a week for that to recover. The lung, more so than the heart, has the ability to regenerate epithelial cells and actually reconstruct itself. So we do have time to help and let it turn around. Sometimes it requires ECMO, cardiopulmonary bypass support, to get the patient through. But if a patient develops severe graft dysfunction, then a third of those patients will die within a month or 3 months. So that's a really, really big deal. And we also understand that it affects long-term survival as well. So what can we do to prevent severe graft dysfunction? Organ preservation, we believe, is a key step. We've done a lot with various aspects of the transplant process, but organ preservation is something we haven't really advanced in since we started the first transplants, actually. So organ quality has a significant effect on early and late outcomes. Transport affects the organ quality. Now we know this because shorter transport times lead to better quality. The shorter the ischemic time, the better the result. Could the mode of preservation affect the quality of the organ? When the organ is in transport from point A to point B, it is without oxygen. If we look at a cell, and this is a heart cell, you can get a sense of what's happening on a minute-by-minute basis. At 0 minutes, that's a cardiac myocyte. You can see those little strands are actually healthy mitochondria. But over time, that mitochondria, that energy-producing substance of the cell, starts to fragment and shrivel up. At this point, when you transplant the organ, this oxidant stress and cell death is activated, and you can lose about 15 to 20% of the organ depending on how long that ischemic time was. This is what the cell looks like with this fiery oxidant stress that's inside of it as it's being transported from point A to point B. What are the solutions? Well, the solutions are to keep the organ perfused. Another one would be to limit the transport time. And then another one, which is the most common, is to use ice to decrease metabolic needs during transportation. So if you drop the amount of oxygen the cells need, they produce less stress, less cell death. That's what we've relied on for going on about 3-4 decades of transplant. Keeping the organ perfused up till now has not been a possibility. You can't, the technology has not allowed us to bring an organ from point A to point B and have it ventilated and have blood flowing through it. That just has not been a possibility. Limiting the transport time is not a great option because then we get offers from California that we can't take or other states outside of our own. And if you just rely on your local population, the wait list would be 3, 4, 5 times as long as it is. Current methods of preservation include ice or Perfidex solution, actually, and Perfidex solution. So ice is pretty easy to understand. We take the lungs out and put them in an ice cooler, and then it's cold, low demands, and we can travel pretty long distances actually, up to 6 hours even in transport. But we understand that if it takes 8 hours to get it in, while we can barely get away with it, you can only do so maybe 4 out of 10 times. So it is a problem. The longer you are on ice, the longer it is. Does ice itself also affect the function of the organ? We're not sure, but I can imagine that Walt Disney, when he gets defrosted, is not going to be quite the same as he was before. So ice probably has some deleterious effect, although we haven't had a choice. Perfidex is a solution that we use, so as we go to the donor and we inspect the lungs, when it's good to go, we put a cannula in the pulmonary artery and we infuse 4 liters of Perfidex through it, and then 1 liter in the back table through the veins. And it protects the microvasculature against post-ischemic reperfusion injury. It prevents the leukocyte endothelial cell interactions, and it prevents edema, and it seems to have some heparin in it as well, so it just sort of counteracts thrombosis. But it's pretty much all we've used for a really long time. That's about as advanced as it's gotten. Can we use technology to do any better than this? So organ care system has come along and really promises to change the field of transplant probably forever. There's a company out of Massachusetts called Transmedics that has pioneered this technology. The CEO of the company was actually a resident in a lab, and during his time in the lab, he decided he became so passionate about the device and its promise that he just found backing and funding to turn that into a corporation, and has finally seen the realization of this over the past year. So if we look back at what we've been doing with ice, it's like driving one of these old initial cars. You translate it into what we have now with the organ care system, and it's a much faster, much sleeker, much user-friendly, but it comes with a lot of responsibility. It comes with more cost, although not insurmountable. And it comes with more promise, but we have to know what to do with it, and we have to drive it safely and understand what we can do. So this is a synopsis of the device. OCS lung, it's a fully integrated, portable, ex vivo lung perfusion system. Not to be confused with ex vivo, which is another type of technology that's similar, and I'll discuss that. The Transmedics has this console right here, which is reusable. And this module here is a sterile module that houses the organ. And this is disposable. You don't use it after each time. There's a gas exchanger. It's similar to in a cardiopulmonary bypass machine where you have the oxygenator, the small oxygenators, which were invented at the University of Minnesota. So the gas exchanger is a miniaturization of that allows deoxygenated blood to then get oxygenated. And there's an integrated ventilator there that functions just like a normal vent does to inflate and deflate the lungs. There's a pulsatile pump built into the system, and we think that's advantageous. Instead of having continuous flow, you actually get pulsatile flow like the lung is used to experiencing, like the heart is used to experiencing too. And then there's a blood reservoir that functions as a venous reservoir, like our venous capacitance is. It comes with Perfidex solutions and a variety of additives that we have to add as well. So here's the device. You see this cannula going into the pulmonary artery, and it's delivering blood flow into the pulmonary artery that gets distributed throughout the lung. We can measure the pulmonary artery pressure, the pulmonary vascular resistance, the saturations, the level of the hematocrit, the amount of oxygenation, how quickly it takes the lung to oxygenate the blood, and another 5, 6 parameters, temperature, flow, etc. You can see it, the blood draining down into the bottom of the well, kind of like draining down into a shower, for instance. And it drains through the drain and then is pumped back up into the pulmonary artery. That's how the blood circulates through the system. We see here a long trachea that's connected to a tubing, and that's how the ventilator delivers air into it. This gives you a better sense of how the actual monitor works. The whole device is about the size of a Foreman grill. It's pretty small. This device we hold on our lap when we're traveling on the plane or in a car. And it allows us, in the palm of our hands, using Bluetooth technology, to understand the behavior of the lung, to understand how much resistance is building up in the pulmonary vasculature, which, by the way, if a lot of resistance is building up, is one of the first indicators that we have that there's something wrong with that organ, that may not be an ideal organ to transplant. In addition, we can treat it. So we have an ability to add prostacyclin, nitric oxide, into the circuit to get the pulmonary vasculature to be more compliant. Talking a little bit about the modes of ventilation with this is very interesting. There's a preservation mode and there's a monitoring mode. 2 different types of gas tanks that we use with 2 different gas mixtures for each of these modes. Preservation mode is basically the mode that we keep the lung in as we travel long distances or any distance. So it just lets the lung relax. It lets it not have to do much work at all. It keeps the blood oxygenated. It also keeps the air going into the lungs oxygenated. So there's no oxygen differential. The lung's not really working. It is expanding and deflating, and it is perfused with blood, but it's not doing much. Now in the monitoring mode, we switch that around. We deoxygenate the blood. And now we test the lung's ability to actually ventilate and oxygenate the blood. So 2 different modes. Here's a closer look at the preservation mode. Here's one alveolar unit. As you all understand, the lung is made up of millions of alveolar units. There's the blood coming into one individual alveolar unit. and then as blood travels away, it gets oxygenated. In the preservation mode, it already has plenty of oxygen going in, so it doesn't really need any more. When we go to assess the lung's function, we flush out the oxygen, and now we allow the alveolar units to work and to oxygenate the blood. This is another system, and it is important to understand that as with any technology, there's going to be competing technologies that will evolve. In this field, there's really only two right now. There's this one, the one that I've just described, and this one. This is static ex vivo lung perfusion. Some promising results have come from this too. One of the original papers in New England Journal of Medicine showed that they could rescue marginal lungs using this system. So there may be applications for this as well. One of the issues that we have had with this is that it's really big. I mean, it's enormous. It takes up at least a good third of your operating room, and you can't transport it. You can't transport this. So you do rely on bringing the organ back to your institution on ice and then putting it on this device, and you don't perfuse it with blood, you perfuse it with a solution. To the extent that that may be helpful has yet to be known. This is a little bit of just showing you the differences. Cold storage for up to 6 hours with the ex vivo static system, and then they put it on the device. So we believe that there's some delayed benefits because it doesn't get on there right away. It's still exposed to ice for about 6 hours. Here you can go with the OCS system up to 10 hours. Actually, frankly, you can go up to 24 to 48 hours. One of the limiting steps is the blood. So if the blood is in there and it starts to hemolyze, we haven't done a lot of this, but after 24 hours, we might want to change the blood that's in there and somehow allow us to have fresh blood. Aside from that, it can be on the device pretty much indefinitely. As Paul alluded to, this device is being also used in the cardiac realm. So this is a beating heart. This is how I initially learned about the company, and I was at Cleveland Clinic, and they were doing some of the original cardiac trials, and the PROCEED trial related to cardiac preservation using the device has already completed its enrollment, and the preliminary results seem very interesting for the heart. The heart really only has a finite period of time, 4 hours. Beyond 4 to 5 hours, it's not that you get delayed recovery, it's dead. So it either works or it doesn't. So there definitely is need to be able to extend ischemic time, especially with cardiac. It's a different module for the cardiac program. For the cardiac, it perfuses the coronary arteries, different types of cannulas, and you also have to pace the myocardium. At the U, we have both a robust cardiac and lung program, but the lung program is the one that has first got started with the clinical trials on OCS. So I'm going to talk a little bit more about how this is affecting our lung transplant program. So how are we studying this technology and how are we incorporating it into clinical practice? So research on normothermic organ preservation has been around for a few years now. This is the first study that the CEO of the company actually did in his residency, and it showed that continuous perfusion of donor hearts in its native beating state improved recovery. New England Journal, using the static ex vivo system, showed that they could rescue lungs that would have otherwise been refused. And then a pilot study in the Lancet showed that 12 patients were successfully transplanted with the organ care system in Europe. That then brought the technology to the US, and the launch of an international registry and a landmark pivotal trial called INSPIRE. INSPIRE relates to standard donor lungs. It's a randomized controlled study that we are a part of. And the EXPAND trial is a second trial that looks at expanded criteria, so more questionable marginal donors that you just need more time to assess. The INSPIRE trial compares the portable ex vivo perfusion to cold preservation. So it's a one-to-one comparison. The inclusion for that is patients younger than 65, normal gas exchange, no active primary pulmonary disease, and the donor lungs have to be suitable for ice or the other, because when you open the envelope, the patient has to understand that if they get it on ice, it's going to be okay. Primary endpoint is patient survival at 30 days and freedom from primary graft dysfunction 3, which is that severe form of primary graft dysfunction that we discussed. And there are a couple of secondary endpoints that they're looking at as well. As of August 13th of 2013, they've had 176 patients enrolled worldwide. Right now we're at 250. The results have been very interesting. The results have suggested that the primary graft dysfunction thus far, and it's being presented this weekend actually, may be a little better. And I can't give away too many specifics, but it's on the order of a 50% reduction in severe dysfunction. And how that's going to translate into survival and long-term effects will be interesting to see. Suffice it to say that it caused the FDA and the industry to switch from a non-inferiority trial to a superiority trial. So now they're just seeking to enroll another 30 patients to prove superiority because of how promising the technology has been. So to give you a sense of how this plays out here at the institution, we were the first ones to do it between the coasts. UCLA did the first one in the US, and Pittsburgh did one, and then between those two coasts, we were the first to start getting involved with this here in the Midwest. This is the first one that we did, and this gives you a sense of what it's like to integrate something this new into clinical practice. It's not easy. There are a lot of points that you have to integrate with your current system. You have to have your current regulations still be a part of the whole process. But whenever you introduce something new, you have to do it safely. The company always has one of the representatives who's here in the audience, and they always have a representative available for these transplants, at least until the institution is 100% comfortable doing them. So we go out on it with a pretty generous team of about 4 or 5 people, including a perfusionist, a representative from the company, and a procuring surgeon and a nurse. Here we've arrived at the center. We've determined that the lung measurements look good. We've drawn a blood gas and said that in fact the ABG is still acceptable. And we're separating the lung. We've flushed all the blood out of it through gravity, and now we're just separating it from the device. We keep it inflated after it's separated. We're bringing it over now for a moment in time. It does have to be on ice as we separate it, but it's on the order of about 30 minutes. It takes 30 minutes to implant each one. So up until now, in our mind, these lungs haven't really sustained any ischemic injury. This gives you a glimpse of the different checkpoints that have to be in place when you're dealing with this. So the EXPAND trial I'd like to talk about for a moment is really the next step. And this is where we're addressing this issue of donor shortage. 80% of organs are wasted, only 20% are used. So the EXPAND trial is looking at donors that on first glimpse you might refuse. So the donor blood gas ratio less than 300, suggesting that those lungs aren't oxygenating well. Your expected ischemic time or travel time greater than 6 hours. DCD donors, which is a form of donation where the patient arrests before they donate, or a donor age greater than 55. So any of these are inclusion for this trial. So we were fortunate enough about a month ago to be the first center in the world to enter in a patient. We entered in 2 patients into the EXPAND trial. And this is the very first one that was done. It was not from a far distance, but it was an older donor, and it was coupled with donation after cardiac death, which is an ischemic insult right away. So taking these 2 factors together, an average of 2-3 centers would refuse these. When they got to us, said, well, with this device, we can put the lungs on the device, and we can decide when we get to our institution whether or not they meet standard criteria. And if they meet standard criteria, then our assumption that these were good lungs was correct. And so that we're not looking to regenerate something that's damaged. We're just looking to prove our assumption that lungs that we would otherwise turn down are acceptable. And so we've transplanted 2 of them using this trial. They're both home and doing well. We've still been the only center that has actually used it for this purpose, but there are many others that are starting to. So both of those patients were free of primary graft dysfunction. So future directions, clinical research, translational research, facility training. We'd like to become a training center for other centers who want to learn how to do this. And with Paul, we're actually launching, this is the first time in the U.S. that we've been able to get a grant to have a device strictly for basic science research. So we're going to have a separate one that is not used clinically that we use for experiments. And there's a lot of different types of experiments that we can conceive of. We'll probably start off kind of calibrating the system, maybe comparing to ice, then using agents, because it's a nice platform to infuse different protective agents, preconditioning agents, to see if your ischemic injury can be reduced on the box. And we get a readout right away, right? We get pulmonary vascular resistance, pulmonary artery pressures, saturations, all these things that can give us a sense of how our interventions are doing. So we get an instant readout, and of course you can do all sorts of different basic experiments beyond there as well. You can also use this as an endpoint to assess preconditioning agents. In other words, you can pretend that that's the patient at the end of a lung transplant or at the end of a heart transplant. And it just gives you a nice controlled, sterile environment to assess what you've done to the lung. So it's going to be very interesting to work with this and to see how we can take it forward, because it is very much in its infancy right now. And Expand is going to start to understand how we can push the envelope, but we're not quite there yet. So in conclusion, technology and miniaturization has allowed organ transportation without ischemic injury. Clinical implications through clinical trials are very important, and we are currently concluding the Inspire trial and looking to launch the Expand trial. And cellular implications to incorporate pharmacology and/or cell therapy will be the future of this. That's going to be the way that we can push it even to the next level. Thank you.
That was a great talk. We have time for a couple questions.
Thank you. That was very interesting. 2 quick questions. My first one is, you mentioned there was a high rate of lungs that were denied from being transplanted. What was the reason for that?
Well, it's an interesting process. I mean, some of them are, you look at them and they're damaged. You know, they're contused because it was a car accident, and that's kind of obvious if it's pretty bad. Other times it's not so clear. You see a patient, they're a little bit older, they'll say they're 56, 57, and they're traveling from a little bit of a far distance, so say the offer's from California, and the recipient is not quite that sick, he could potentially wait, and the blood gases have been kind of marginal, they've been 290, they haven't really hit 300, and I'm not sure, I think they might be okay, but we're not quite sure, so we'll turn them down and just wait for more of a much more definite organ, one without any evidence of injury on imaging, and one with blood gases that are well above 300. And so what this would allow us to do, what we're using it for with Expand, is to go ahead and try the organ. We don't transplant it. We bring it here. The patient is not even opened or prepped yet until we assess the lungs here at the institution.
Thank you. And my other question is, I understand the logistics of this would be very difficult, but why don't we transport the donor rather than the organ itself?
So to transport the donor itself. Well, so that's when we have local donors, let's say Hennepin County, or let's say Abbott Northwestern has a death, or even here there's a death, then that's feasible. The problem is that every time, for any donation, there's not only the lungs, there's the heart that gets donated to another state, and then the kidneys, the pancreas, the liver. Really, for any donation, there's a lot of organs and a lot of lives that are saved, but they're all around the country and sometimes around the world. Canada, Puerto Rico, So that's the issue. And what we're trying to do with this technology is almost like bring the donor to you the best way we can. Sure.
Wonderful talk. I really enjoyed that, especially since we are the recipients also of doing lung transplants down in Jacksonville at Mayo. One of the things that I'm wondering about is, especially when you brought in lungs and we're going to split them, I assumed you were splitting them into 2 patients doing 2 singles. Do you also find that with resource utilization, for example, the operating rooms, you often don't have ORs just sitting around, so they're good enough that you can do them at either better hours, you can also do them when their rooms are more available, et cetera, et cetera. How has that impacted your resources? And the second thing was, in terms of some of the controversial data that you were talking about, potential research in the future, there's been so much discussion on low tidal volume ventilation and damage to the lung. All that has been, I've been doing this stuff for a long time, and I'm not sure I believe all that data, and this would be a wonderful way to really put somebody on a long-term ventilation and really look at the changes over time in a very controlled environment. I think it would be fantastic. So,
yeah, absolutely. So for the first question, in terms of splitting the lungs, that makes a lot of sense. It turns out that for the trial purposes, they're asking that they be bilateral. So we can't do that yet for the trial. Clearly, you can do that once it's completely approved. But there's a little bit of unpredictability with how a single will act versus a double. So that's been their concern. I think it would have been nice if they allowed them to be split. I think it would have had faster entry, but it's a reasonable concern. And then with the next point, in terms of resource utilization, yeah, that's been something that we've been really looking at in terms of can we delay this for a more reasonable start time when the team is much more wide awake and everybody's ready to transplant and wait till the morning. We're definitely doing that with Expand, because for Expand, once we arrive with the organ, it then takes us like another hour or 2 just assessing it, since we can't commit to the transplant yet. So we are kind of pushing the envelope in that regard. I think that is going to be fine, but we still don't know 100%, quite how long we can leave it. We assume it can be for days and all that, but in real practice, it'll be interesting to see how much that time on the pump really affects things or not. Thus far, it doesn't seem to in our experience. But we'll want to collect it so that we can then truly commit ourselves to delaying a procedure and waiting a little longer. And then the final question, yeah, I think we can have like an ARDS model, a pulmonary contusion model. You put them on the device, and then you study low tidal volume versus higher tidal volumes and see what it's doing in pulmonary vascular resistance and any other endpoint that we might be interested in looking at. So absolutely.
One last question.
Have you considered using antioxidants to reduce the ischemic reperfusion injury?
We've intellectually thought about it, but we haven't really committed to trying it just yet. That might be one of the things we try, either N-acetylcysteine in the circuit, or one of the other commercially available ones that we could try to see if that does actually reduce our ischemic injury. And then we'll want to actually be able to demonstrate our ischemic injury too, maybe through pathological sludge or endotoxins and whatnot.
Well, let's thank Dr. Loor one more time.